So yet another neuro talk. Here we go. Parkinson's disease, not Parkinson's disease. We've kind of moved away from that. So it's now just Parkinson's disease. So the most famous person that I know with Parkinson's disease is Michael J. Fox. And Michael has had it for many, many years now. He has substantial issues with movement of his right arm. He's increasingly had a mask-like face. He's got issues with his gait. And he's had these things for many years now. You can see the difference in his face. You know, here back in the 1980s, he has a much more animated face. And here you can see he's much more mask-like, much less emotion that you can see on his face. So the case I'm actually going to talk about is a patient that's in a long-term care facility, a Mrs. Lincoln. And Mrs. Lincoln is an elderly woman. When you see her, she has small steps. They increase in length. That's a specific type of gait associated with Parkinson's disease. If you bump into her, she might fall backwards and actually even walk backwards if you bump into her. And she's also starting to have some difficulty with swallowing. She is obviously a much more advanced case than Michael J. Fox. So what are those things? Well, that's called a festinating gait with those small steps. Usually they become increasingly long and they almost will start to, it looks like run as they walk. That's called a festinating gait. When you bang into them and they keep going backwards and can't right themselves, that's called retropulsion. And when they move slowly, that's called bradykinesia. Obviously, the difficulty swallowing is called dysphagia or dysphagia. Technically, dysphagia is probably the right term, but almost everybody in rehab calls it dysphagia just because it's easier to figure out when you're talking about dysphagia with a G. Dysphagia with an S also can mean difficulty with speech and language. And so most of us, when we're talking about swallowing, if you've ever worked in a rehab setting, usually we'll talk about dysphagia. Again, signs and symptoms. This lady has a mask-like face. She has a non-intention tremor. That is a resting tremor. So when you're resting, your tremor is there. When you go to do something, it seems to go away or at least substantially decrease. This is very different than an intention tremor. An intention tremor is when you're sitting there and you really don't see much movement of the hand, but when they go to reach for something, you see a substantial shaking of the hand. An intention tremor is most likely just benign familial tremor. That's the most common cause of an intention tremor. It's usually not anything terribly neurologic, although you do need to go through a full differential diagnosis process to figure that out. People, however, that have a non-intention tremor are much more likely to have Parkinson's disease. Pill rolling is something that happens in which they take their thumb and their forefinger and basically they act as if they're rolling a pill. This is a specific instance in which you will have a behavior that's almost always associated with pseudo-Parkinsonism, which is side effects from long-term psychiatric medications. So the people with Parkinson's disease will lose dexterity, they'll lose muscle control. One of the early signs of Parkinson's can be when they start to write very small. So if you have somebody and you compare their handwriting sample from 5 years ago to now, and they've decreased in size by half, we call that micrographia, and that is usually associated with Parkinson's disease. It makes sense. What's happening is they're concentrating so hard and trying so hard to write that they actually find it easier to write smaller because if they're using bigger movements, they have more tremor. People that have advanced Parkinson's disease often have a hard time feeding themselves, and then you'll actually start to see weight loss and you'll see other symptoms associated with it. In very advanced cases, they'll start to drool, they'll start to have dysphagia, and they often will have orthostatic hypotension. So that's blood pressure that drops when you stand up. Treatments for Parkinson's, we're going to talk about pharmacology in a minute, but there are surgical treatments. They can implant brain stimulators. There's some new research that's going on with fetal tissue transplants in which they're trying to grow new dopamine-producing cells. That's still very experimental at this point. So when someone is trying to move, whether you have Parkinson's or not, generally this requires a balance between the neurotransmitters acetylcholine and dopamine. If there's a problem with the development of dopamine, and most dopamine is produced by neurons within a section of the brain called the substantia nigra. If that happens, then you don't produce enough dopamine and you have too much acetylcholine. What can we do? Well, we could try to decrease acetylcholine, and that's what we used to do back in the 1960s before we had drugs that would increase dopamine. We would try to decrease acetylcholine, and we would give anticholinergic drugs. And as you remember, the major side effects of anticholinergic drugs are can't see, can't spit, can't pee, can't defecate. So they have lots of side effects. So it's much more desirable to try to increase dopamine. So just going back, to decrease acetylcholine, you give an anticholinergic. Now, to increase dopamine, what can you do? Well, you can give something that interferes with the enzymes that break down dopamine. This is a common strategy for trying to increase neurotransmitters in the body. And we know that the enzyme that breaks down dopamine is monoamine oxidase. Now, anybody that is familiar with psychiatric drugs know that MAO inhibitors are very difficult drugs to manage, have a lot of side effects, they have great dietary inhibitions, but fortunately for us, that's the MAO-A component. MAO-B inhibitors really do not have any dietary restrictions. They basically just inhibit MAO-B. That increases the amount of dopamine circulating and will decrease symptoms of Parkinson's disease. So the most common of these, saligeline, is an older medicine. Rasagiline or Azilect is the most common one that's currently used. So what else could we do? Well, we could actually give something that the body will convert to dopamine, and that is something called levodopa. Anybody that's seen the movie with Robin Williams about the folks that had Parkinson's disease, I believe it's called Awakening or Awakenings, will know that levodopa was given to those folks and had a dramatic impact. The problem is that the levodopa has a lot of side effects and the effect wears off fairly quickly. It causes a lot of nausea and vomiting. And so we figured out that what we can do is we can give a medicine that interferes with the breakdown of levodopa in the periphery, the conversion from levodopa into dopamine. And so what happens is it stops the dopamine from being converted out in the periphery, but it doesn't stop it in the brain because the carbidopa does not cross the blood-brain barrier. And so basically it decreases the amount of levodopa in the periphery, decreasing the nausea and vomiting and other side effects, but increases the effect in the CNS, giving people with Parkinson's disease much better effects. Carbidopa, levodopa, given together, is known as Sinemet, and that's the most common Parkinson's disease that many of us are familiar with. There's other ways that we can get dopamine type effects. We can give other agonists, bromocriptine and pergolide are medicines that look like dopamine to the body. The problem is that they're not quite as effective and their effect also wears out. Another thing we can do is we could use another enzyme that is involved in blocking the effect of breaking down levodopa and keeping more levodopa in the circulation. And these are COMT inhibitors, and the most common COMT inhibitor is something called entacapone. Entacapone is also known as Comtan, and Comtan is a medicine that is used. Stalevo is a combination of carbidopa, levodopa, and entacapone. And so this is yet another methodology. Generally, these are neurologists' medicines, but it is interesting to know how they work. There's some other drugs on the horizon. Xadago is another MAO-B inhibitor, which is being marketed. I'm not sure that it's any better than any of the others. Exenatide, which is a GLP-1 agonist, seems to have been found to have some benefits from Parkinson's. It's obviously a diabetes medicine that we're all familiar with, a GLP-1 agonist, but it does seem to have some benefits, and that's actually being studied now, and it may actually start to be used more for diabetes. Other issues in diabetes, obviously nutrition, mobility, respiratory, because they decrease their motor strength and will start to have pneumonias, urinary retention. Again, they don't have the ability to urinate as well because of decreased motor function. Same thing with constipation. People with Parkinson's disease also get dementia. Probably related to that imbalance of acetylcholine in the brain. And so it is interesting because they do not respond, obviously, to the Alzheimer's meds because those are supposed to increase acetylcholine. And in people with Parkinson, they basically have too much acetylcholine in relation to the dopamine. So it's a very different type of dementia. And somewhat difficult to treat. We're going to segue here. We'll talk about dementia on another talk. We'll talk about seizure medicines on another talk, but this concludes this talk.